Hello and welcome to the joint colloquium series of the History of Science, Technology, and Medicine and the Minnesota Center for Philosophy of Science here at the University of Minnesota. Today, we are having our annual Science Studies Symposium. For those who are new, this is our once-a-year opportunity where we look to other members of the University of Minnesota community who are working on historical and conceptual issues in the sciences. And it's my great pleasure today to introduce Stephen Stovitz, who is coming to us from the Department of Family Medicine and Community Health. I have gotten to know Steve over the past few years in a number of reading group contexts, as well as the course Conceptual Issues in Medicine that we taught together last spring. And he is a family physician and specializes in primary care sports medicine. He's associate editor at the British Journal of Sports Medicine and Medicine and Science in Sports and Exercises. His main interest is the interpretation and translation of research findings for the practice of evidence-based medicine, and he's an evidence rater for the McMaster's Program for Evidence-Based Resources. He also has particular interests in how the principles of causal inference apply to clinical decision-making, and also in how the statistical literacy of clinicians affects the shared clinical decision-making process. He also is a physician for the USA national volleyball teams. And today he's going to be talking about evidence-based medicine is stuck, suggestions to unclog it. So please, Steve.
Thank you very much, Alan. And thanks to everybody for attending. I'm going to start sharing my screen. Thanks for the introduction. That's who I am. I'm a family doc and at the university, and it's really nice to see some friends on the attendee list and lots of other people who I hope are future friends. So to start off, a general question might be, so I'm interested in research methods and I'm a family physician. And sometimes people look at me like, what is a family doc doing being interested in research methods? And I would argue that for the scientific process, we're actually much more alike than unalike. And what I mean by that is I view myself clinically as a generalist, and I view my research interest as a generalist. So, in family medicine, we take care of kids, we take care of older individuals, we take care of pregnant women and people with heart problems and knee and hip problems, and we do preventive medicine. And the topic of research methods and how, when I use the term research methods, I'm using it broadly as how we best conduct, gather, interpret, and translate and communicate evidence for the betterment of public health and individual health. And that would pertain to specific issues of the whole scheme from dementia to HIV, social issues of crime, education, smoking, happiness, whatever topic you want. I think research methods pays attention to it, and I think the same for family medicine. So getting to the topic of evidence-based medicine, I would just basically my career, I remember back when the term first was coined, which was the late 1980s, which had it where we had, before evidence-based medicine, we had what we call expert-based medicine, which was where people would go to their clinician and the clinician would say to do something and the person would ask why. And the answer was kind of like, because I say so, or because my experience, my experience is people do better with this, which just means the people who didn't do better didn't come back to see the clinician. And so then in, the late 1980s or so, the topic of evidence-based medicine, or the coining of the phrase evidence-based medicine, came into being. And it was led mostly by some physicians and researchers, mostly in Canada, David Sackett being the preeminent name. And what it does is it calls on clinicians to use the best available evidence along with patient values and preferences when making medical decisions. And it's been around now since, as I say, since the late 1980s. So gosh, going on 40 years here. And I just want to make it clear, this presentation is going to be about problems with evidence-based medicine. I want to make it clear where I'm coming from. I agree with the principle of evidence-based medicine. I think that the way they worded it was quite brilliant. I do not fault evidence-based medicine for being too robotic or uncaring or neglecting the art of medicine. And I bring those up because when I read articles that criticize evidence-based medicine, it's generally for these things. It describes it as being robotic or neglecting the art. I work at the Mill City Clinic in Minneapolis, and my colleague is John Hallberg, who is on the radio, and he talks about the art of medicine, and we actually have a center for the art of medicine, and that's evidence-based medicine. I mean, nice art and classical music and stories make people feel good. That there's nothing non-evidence about that. There is evidence to state that. So those are not my problems with evidence-based medicine. My problem that I'm going to discuss during this presentation is how we conduct and interpret medical evidence. It's with the application of it. So that's what I'm talking about, not with the art of medicine. I don't see that as contradictory. So my objectives today are to recognize that evidence-based medicine is now stuck. And I would argue that JAMA, the Journal of the American Medical Association, is not helping. I'm going to present and go into detail of a case study to show how evidence-based medicine is stuck. I will then offer solutions to help EBM fulfill its goals. The solutions that I'll discuss are primarily to teach the evaluation of evidence from a causal viewpoint, and recognize that the same data can provide a valid answer to a prognostic question, but a biased answer to a treatment question. There are many other problems with evidence-based medicine currently in its form, and the big one that I think is, well, at least it's on my mind, is the problem we're having now with publishing. The sort of predatory journals and the lack of peer review and the current system needs some change. I'm not going to discuss that today, but I am super interested in that if others on this call want to discuss that at another time. So I'd like to start from this vantage point. If you showed a clinician the following headline, this is a fake newspaper, the Minnesota Times, which finds this study that red wine drinking is linked to a longer life. And this is a fake study, but something we read about quite often. It's mimicking that. Researchers analyzed the health records of this large number of adults over the age of 75 and found that those who drank red wine lived an average of 2 years longer than those who did not. So that would be the study. If you asked a clinician, does this support advising non-drinkers who are age 75 and older to start drinking? I would think that we can imagine what most people would say. Then show clinicians the following headline: walking linked to a longer life. A new study of researchers at the University of Minnesota analyzed health records of a large number of adults over the age of 75 and found that those who walked more than 1 hour a day lived an average of 2 years longer than those who did not. And ask the clinicians, does this support advising sedentary individuals to walk more? So in my experience, and I have done this when I talk to clinician groups, in my experience, and this is not for everybody, but most people would claim that most people would, in the red wine story, would say, well, probably not. It's probably that people who are wealthier drink red wine and people who are wealthier live longer because they have less pollution in their air and less stress in their lives and cars that get in accidents less or whatever else. And that's why they live longer. But on the second study, the clinicians that I work with would go, yeah, I believe that. I think walking is really good for people. And when I have a sedentary person, I tell them to start walking. I would just like you to appreciate that the studies were the exact same. The studies evaluated people over 75, looked at behaviors, and we simply imparted our cognitive bias into what we would advise our patients to do. So this is 1 week in the history of JAMA. This is just a random week. I get these all the time, but the studies, if you look at JAMA closely, it's association of aspirin with mortality risk, association of this revascularization with stroke or death. It's association between marijuana use and risk of cancer, association of work schedules with patient outcomes. In fact, if you look at the author instructions for JAMA, they specifically do not allow you to use any terms of causal language, except for a randomized control trial. In fact, they don't let you use causal language for a meta-analysis of randomized control trials. It is merely associations. So this association between marijuana use and risk of cancer is a meta-analysis of randomized trials, but they can only say association. So sticking on the marijuana for a second, let's take a hit from the marijuana study, just a joke there. I think that we all would say, well, do we think marijuana use causes cancer? And let's say the study found that there was an association. And let's say our preconceived notion is that marijuana causes cancer because it changes the lung tissue. Well, then we would read cause into that. If we don't think marijuana use is bad for you, then we would say, oh, it must have been that poor people smoked marijuana, just like the poor people didn't drink red wine. So that's just my experience. When you use the term association, people throw in their own cognitive biases to their interpretation of the studies. So the problem that I see with our current teaching in medicine is that the medical students, and this is to this day, are taught correlation is not causation. And this, I think, follows in medicine. It's similar to the phrase "above all, do no harm." They sound wise. There's nothing sort of untrue about them. In fact, the correlation phrase is actually true. I would argue that I don't know that above all, do no harm we actually do, because sometimes you actually, would for instance, perform a surgery which could cause harm, but would hopefully benefit the person in the long run. So I don't know that we actually practice above all, do no harm. But anyways, both phrases sound wise. The correlation phrase is actually true. My question is it helping? My suggestion is that we should teach principles of causality at the start of medical school. In fact, I think we should teach it at the start of college. In fact, I went to my kids are now in college, but when they were in high school, I went to their classes and I taught what's going to be, I think, the next slide. Yes, it is, to them, and they pick it up. We are supposed to be improving science, bettering people's health, and I think it's incumbent upon us to ask, why do things occur? There is randomness in the world. Sometimes things occur randomly, that's for sure, but that's why we're supposed to repeat studies. I think to avoid causality doesn't get us where we need to be, at least in medicine. Evidence at its core is relationships between variables, and I think it's incumbent upon us to ask the question, why? If you find two variables, let's call them A and Y, that are associated, we must ask, does that association reflect A causing Y? And I've put together what I feel are sort of 5 fairly encompassing drawings to describe why A and Y might be related. It might be that A causes Y, and then it does reflect A causing Y. It could be that B causes A and B causes Y, and we would call that confounding bias, and that would be like the wealthier person drinking red wine and the wealthier person living longer. It might be that A and Y both cause C, and we condition on C, and that's called selection bias, and that's the case study I'm going to discuss, because this is the one that I think is really hard for people to grasp. It could be that A causes D and D causes Y, and we adjust for D, so we actually mess up the relationship for A and Y, and that's over-adjustment bias. And it finally could be that Y causes A, and then you have what's called reverse causation. Do we know when we do the study whether A causes Y? We don't, but we must ask, and ignoring it doesn't cause it to go away. Our current system for evaluating causality, I'm not sure, different people on this call and different disciplines may use different formats, but this is still taught in actually, I just got the slides this week from the current med class. This is still the teaching, is the Bradford Hill criteria. There's nothing against Bradford Hill. He did not call these guidelines or anything. Strength, consistency, specificity, temporality, et cetera. And that's what the current teaching is. So what's the problem with avoiding causality? And I would like us to consider the so-called obesity paradox. And this is the case study that I'm going to describe. I can't ask a show of hands because you're all on Zoom, but maybe some of you have heard of this. I assume many of you have not. What the obesity paradox is these 2 findings right here. Bullet point number 1, it is very clear that obesity causes heart failure and other obesity-related comorbidities. And I like to focus on heart failure because, well, heart failure, there's actually no specific ejection fraction that is determined as to be heart failure. So simply actually weighing more can turn a person from not heart failure to heart failure. So there is kind of no debate that being heavier causes heart failure. I don't think there's a debate about it. So obesity causes heart failure. It also causes a lot of other problems. And when I use the term obesity too here, I just want to make it clear, I am just referring to elevated BMI, elevated body mass index over 31. Yet, when you study among people with heart failure and or these other comorbidities, diabetes, atrial fibrillation, stroke, hypertension, whatever, those who are obese do better than those who are not obese. So obesity causes the problem, but when you study people with the problem, the obese do better. And those are 2 facts that occur in the world. These articles commenting on the obesity paradox started in around the year 2002 and 2003. They then started to skyrocket and reach nearly 300 by the year 2013, when my people I didn't know then, now my good friends and colleagues, Haley Bannock, who's now at the University of Buffalo, and Jay Kaufman, who's the head of epidemiology at McGill, wrote The Obesity Paradox Explained. They explained why we find these 2 things. And given the current state of publications and peer review, this did not stop articles. And by January 1, 2017, when I did a search of this, there was over 800 articles commenting on the obesity paradox. And now, as of January 7th, 2021, when I just looked it up, there are almost 3,000 articles on the obesity paradox. So there are about 500 articles a year on the obesity paradox. Some of these are definitely critical of this, but most are not. They report it, it's with fascination, they call for further research. There's 2 to 5 articles per week. There's now meta-analyses on these, there's systematic reviews, a decade of evidence about them. These are proponents that this is some medical mystery that needs to be solved. There's now obesity paradox in stroke, obesity paradox in liver failure, cirrhosis. There's obesity paradox in other continents. Is the obesity paradox in Asia? Does it persist in Israel? I'm sure that, some of you have already, kind of figured out the problem here. And the problem is that the obesity paradox is not a paradox. And when I say it's not a paradox, that's kind of a semantic issue. I believe it's not a paradox. There's actually, it's unclear, depending on which definition you use of a paradox, you could say it's a paradox. My definition of a paradox is, something where there's 2 facts and I can't explain why they both exist in the world. And here I think we can explain it. And I think the results are logical if you evaluate it from a causal pathway viewpoint. So from a causal pathway viewpoint, we have that obesity causes heart failure, and I'm calling this heart failure from obesity, and we would define that as heart failure. And since all studies are a comparison, you're comparing the people who have heart failure who are obese, they are compared to the people who have heart failure who are not obese, there must, and I'm using that term very specifically, must be another cause for heart failure. Otherwise, there would not be any people in the study who are not obese. So really, when we're studying these people with heart failure, we are not studying people who are the same other than the obesity. These groups are not exchangeable. The people with heart failure from other things are not the same. They have another cause of their heart failure. And because those other causes of heart failure are worse, they do worse. This is no different. I've got slides that I moved to the end for the sake of time, but in the 1950s to 70s, they noticed that if you took just small babies, those born to women who smoked did better than those born to women who didn't smoke. And it's because smoking causes small birth weight babies. And the ones that were born to women who didn't smoke had another cause for being really, really small. Those did worse. If you take people who, and this study just came out, if you select people who have lung cancer, smoking doesn't seem that bad. Sports medicine, a study that just came out, if you take people with dementia, concussions don't seem that bad. Meaning that the people who didn't get hit and have a bunch of concussions have another reason for their dementia. So it's all the same sort of structural standpoint. This is not the topic of my slide, but there's also confounding bias when it comes to studies of death in people. So I've got this like it's a secret, but it seems to have been forgotten. This was known in the time of Hippocrates. Dying people lose weight. They lose weight, and it's not just in the final days before death. The cachexia before death starts well before death. Some people estimate 10 to 15 years early. So there's actually also what we would call confounding bias here, because there's a body weight from declining health, which leads to your measured body weight and also leads to death. So there's also confounding whenever we're studying processes of weight with death. If you follow it to death, dying people lose weight, it seems like weight loss is a bad thing. Going back to the selection bias, what we call collider stratification bias, this has been explained repeatedly. Haley and Jay explained it. Preston and Stokes wrote something. This crazy family doctor from the University of Minnesota wrote something. Ian Schreier from McGill wrote, "The Obesity Paradox is not a paradox." There's been lots of letters written that this is not a paradox, and it's easily to explain why this occurs. These are some of the responses to these letters. We've seen this, and this is because we don't teach causality. We've seen the same phenomenon in 6 studies of 22,807 patients and a meta-analysis of 89 studies in 1.9 million patients, and another meta-analysis of 97 studies in 2.9 million people. Denying the obesity paradox is foolish. So I would ask you all, is this not the definition of a bias? The definition I'm reporting here or using here is a systematic error that does not correct itself if you repeat studies using the exact same study design. That's, this is not a random error. This is a systematic bias. And because we don't teach causality, they don't see the systematic bias, and they keep repeating studies and being fascinated and calling it a paradox. This is in a letter in 2019 that Ian Schreier and I wrote. We said that, there's a logical problem, and that the citations are simply citing themselves. And in one study, they cited themselves 13 times. And so Ellen kind of likes this one, and I removed the name. So, but this was the reply. And I quote, "They mention that we cited 13 of our articles, but if they look up on this Expertscapes, they will see that one of us is ranked first in the worldwide on both the topics of obesity and fitness, and that this other person has 800 articles currently on PubMed, so 13 represents a very small percentage." So, this is what we're at with science right now. And I would just ask, is science no longer a self-correcting process? And I know there's many people trying to combat this. Brian Nosek, who I think has spoken to this group, from University of Virginia, one of the leading names, to try to stop this issue in evidence-based medicine, which is the problem we have now with publications and peer review. Now, to just be clear, randomized controlled trials, not observational trials, randomized trials where you take people and you randomize them to behaviors that would get you to lose weight versus not behaviors that would get you to lose weight, repeatedly demonstrate that intentional weight loss is helpful. Okay, this happens in every randomized trial. Intentional weight loss is helpful. It's the unintentional weight loss from the dying process, and it's the study designs that cause these confusing findings that you don't see if you don't look at things from a causal viewpoint. And the importance here, this is not simply again, this is not just a semantic issue or people picking their umbilicus, as Alan would say, their belly button issue. This is affecting recommendations. So here's a study, a randomized clinical trial in JAMA. So as you'll see, they don't use the term association. They talk about effect because this was a randomized trial where they had caloric restriction or exercise training, and they measured oxygen consumption, which is a sign of health, and quality of life in obese older patients with heart failure. And just like the other randomized trials, they found that diet and exercise led to weight loss, fewer symptoms, and greater exercise capacity. However, they wrote this in the discussion. Quote, "Because of the reported obesity paradox, lower mortality observed in overweight or obese individuals, before diet can be recommended for obese people with heart failure, further studies are needed to determine whether these favorable changes are associated with reduced clinical events." To which I would say, really, are we really not going to recommend diet? I'm a family doctor. If I see a person who has a BMI of 40 and is suffering from heart failure, do I really say the jury is out? We don't know if diet and exercise are helpful. Now, don't get me wrong. I understand the problems of diet with people have tried to diet before and it's really hard and it's difficult and all that kind of stuff. I'm not saying it's easy. I'm not claiming there's a magic wand. Exercise is hard. Exercise also causes acute problems. Some people have a heart attack when they exercise. I understand there's subtleties in this, but really, are we not recommending a healthy lifestyle of healthy diet and exercise in these cases because of this obesity paradox? Here is a consensus statement from some heart failure society, which says, quote, down here, unlike the use of weight loss for the prevention of heart failure, the presence of this obesity survival paradox complicates the case for routinely recommending weight loss in established heart failure. And that is highlighted in this other study called the friendly fat theory, which this study says, and they state that high adipose tissue is unhelpful before you have like heart failure or hypertension, but then it magically, there's like this twist that occurs in the body and it becomes really beneficial. And it's very theoretical. I don't think it's based on anything, but that's how they're trying to explain this. And finally, the last one I'll say, this is the section on showing how this is affecting clinical management. This study is Obesity Paradox and Heart Failure, Statistical Artifact or Impetus to Rethink Clinical Practice. In any event, a clinician who counsels a patient to lose weight is not directly inducing weight loss per se. Rather, the clinician is leading the compliant patient to initiate an attempt at weight loss. The obesity paradox does not, to our knowledge, provide any direct and compelling evidence contradicting such an attempt, which I think this means I'm supposed to recommend weight loss, but hope the person doesn't actually lose weight. But I'm not quite sure. So from our current structural viewpoint, the way that evidence-based medicine is currently being used, we have the Bradford-Hill criteria. And I would just like you to appreciate that the evidence in favor of higher weight being beneficial, I guess, is very consistent. It's shown in every study. Of course, it's temporal because the heavy weight occurs before death, or the loss of weight occurs at death. Biological gradient, well, I mean, there are some studies that there's a J curve, and when they're very, very, very heavy, it's not so much, but not so much. Plausible, you could make arguments that more body weight leads to more body muscle mass, stronger brains, less fractures. There's certain arguments. So, it fits many of these. When we get to the evidence-based pyramid, I want you to appreciate that all those studies are cohort studies. Then they do meta-analysis and systematic reviews, which are actually the top of the evidence-based pyramid. They kind of skip over the randomized controlled trials, which are hard and only have a few people in them and don't usually follow people to death. They usually follow people for a year or two. And like that study I showed in JAMA might show better exercise capability and better quality of life, but they don't follow them to death. In general, randomized controlled trials don't, because it's hard to follow people for a long period of time. And these cohort studies are done on millions of people because it's kind of easy to do them. So we do have meta-analysis and systematic reviews claiming that, higher body weight is helpful. So to be clear, the data is what the data is. From a prognostic viewpoint, among people with disease, the heavier do better. And from a treatment standpoint, these observations, in my opinion, do not support weight gain for obese people with cardiovascular disease. However, clinicians are not taught to separate relationships into causal or non-causal associations. Recall the language of JAMA, which actually prohibits it. So what to do? Jay Kaufman and myself and Haley were kind of frustrated, and we figured, well, what if we did our own study? And we did it at the University of Minnesota, and we submitted it to the British Medical Journal, the Christmas edition, which some of you may be familiar with. is an edition which does kind of tongue-in-cheek studies, but they're real studies. So we felt this would fit. So we did a retrospective chart review of about 7 years, and we did youth, and took all youth between the ages of 4 and 19, and they had measured height, weight, and BMI, and they had an A1C drawn, which is the test for diabetes. And I've got 3 asterisks because I'll show you why in a second. We had 5,700 individual patients de-identified. It was a pretty diverse group, 57% white, 43% non-white. About half were obese. The second highest category was healthy weight. And there was diabetes in 16.5% of the subjects we studied. What's the problem with the study design? Is that we conditioned, we stratified, we selected on getting a test for diabetes, okay? So obesity is a cause of diabetes. Appearing ill is the reason why a non-obese teenager or adolescent or young child would have a test for diabetes. We created a non-causal inverse relationship between these two. If you are not obese, you must have appeared ill. Oh, by the way, just to be clear, there are, and this is why we did the study, there are 2 types of diabetes. Obviously, there's type 1, which is insulin dependent, doesn't have anything to do with body weight. And then there's type 2, which is generally non-insulin dependent, and that's generally the heavier kids are getting that. We would argue that the 2 types of diabetes are no different than 2 types of heart failure. There can be heart failure from you have a normal heart and you just gain 20 pounds and you have heart failure, or you don't have quite as good, or you have a heart, then the heart goes down due to something else. You got an infection, you got COVID, you got some other cause for it. There's always 2 causes of things. We simply categorize them as one. So the test was for diabetes, and we were comparing those who were obese and basically those who appeared ill. What we found was this. We found that the pre-teenagers, I'll focus on the pre-teenagers, 3% of the obese pre-teenagers had diabetes. They had an A1C above 6.5, and 39% of the healthy weight, normal weight, pre-teenagers had diabetes. So the relative risk here was 13-fold greater in those kids who were of healthy weight. As a small sort of thing of interest behind the scenes, I did not tell our statistician that I expected these results. I did not tell them anything. They kept trying to get me to write my hypothesis when I submitted this study, and I just said, I don't know, we don't know enough. And she thought she did it wrong. I said, no, you didn't do it wrong. This is the reason why, and I diagrammed it out, and we repeated it, and this was the actual stuff. So the p-values are really low, 13-fold increased risk in healthy weight. We submitted to the BMJ Christmas edition with the title, Healthy Weight is Unhealthy, the Protective Effect of Obesity on Diabetes. Our keywords were obesity paradox, selection bias, collider stratification bias, and horseshit. We said the results described are complete horseshit. By the way, horseshit is like listed in like, I don't know, 300 titles of studies on PubMed. So I'm not saying anything that's not out there. Worse words are out there. So we described that we were doing horseshit. This was just bad. This is not good research. But we couldn't stop it any other way. And we were rejected. And the editor said we had concerns that the results might appear misleading if published as research, which kind of pissed me off because we did nothing other than describe the systematic causal bias from the other studies. There was nothing different that we did. We selected amongst a group, we compared the obese to the non-obese, and we described our findings as horseshit. So anyways, we then submitted to the BMJ's Journal of Epidemiology and had a more calm title, Pediatric Obesity Appears to Lower the Risk of diabetes if selection bias is ignored. We stated clearly in this abstract that we were just frustrated with this onslaught of articles reporting fascination with results that appear paradoxical but are merely due to selection bias. We described our limitations, that the heights and weights were measured by clinic personnel and then had a possibility of mismeasurement. And of course, BMI is an imperfect measure of obesity. We had many strengths. It appeared to be a high quality publication. We conducted it at a major medical center. We did it at the University of Minnesota. We abided by all the tenets of scientific guidelines. We attached a strobe checklist as an addendum. We had a diverse group of urban and rural, so you might think it's generalizable, but it's not because it's wrong. We had large numbers and really low p-values. So you might think there was some truth in the findings. No, there is not. And then we stated that our findings, because the p-values were so low, our findings, while wrong, are unlikely to be due to chance. So that's where we're at. I wish I could see your faces, but we're going to have a question and answer in a few minutes. So what can we do? So I'm going to offer some suggestions. We can try to create an on-call force to catch and reply weekly. And these are some of the articles. This is another one written by a physician, Dr. Peters, who I don't know her in Australia. Journals should no longer accept obesity paradox articles, but that doesn't seem to stop them. The current peer review process will overtake any of these attempts. We could do more studies with paradoxical findings and then explanations debunking the results, and I'm happy to participate if anybody has any ideas. I've got some about other studies we could do, but none of this seems to be working. So what I would suggest is that we should teach clinicians causal perspectives from day one. I don't think this would solve everything, but it might help. I think that research should be taught from the perspective of the question and not the hypothesis. There's nothing, I know that many on the call probably are going to disagree with this. I don't think there's anything wrong with hypothesis testing, but if you would specify your question, if we would specify among people with heart failure, do those who are obese live longer than those who are not obese? Then we'd answer yeah. And from a predictive standpoint, if I have 2 patients with heart failure, I could definitely tell the person who's heavy that, you know, kind of I've got bad news and good news. Bad news, you got heart failure. Good news, you don't have heart failure like those other people who have heart failure, you know, who have another cause for it. I don't think people want to really hear that. But that, anyways, I think clinicians should be taught, I think all medical teaching should be taught in terms of diagnosis, which is also prognosis or prediction, versus prevention and treatment. And the way that when I teach about this or I think about it, I just say when I'm interpreting research, I think about what a clinician might say to a patient. And I think that we need to recognize that selection bias is much more difficult to understand. It plays with our brain. It's harder than confounding bias. The red wine study, if I had said, you know, organic red wine from the Loire Valley, those people live longer, you would immediately go to, you know, they're wealthier, they live a healthier life or whatever, other reasons why they would live longer. And you'd be basically describing confounding bias. I think selection bias can be much more subtle if you don't specify the question and look at associations between variables from a causal perspective. So I think we need to study that, ask the question, why are Y and A and Y associated? Now, the arguments against doing this would be, I'll start with number 2, it'd be very difficult to teach teachers. Basically, it'd be very difficult to teach, you know, my age folks to think this way when they have been trained to not think this way. And to that, I would say, yes, that's true. It is hard to change patterns of teachers. I would hope that we could move beyond that as a stopping point for why we don't do that, change this. The other argument would be clinicians will then interpret causation where causation doesn't occur. And I would argue that we already do that. When we read that two things are associated, if our cognitive bias is that walking is good for you, we quickly just go to, I'm going to recommend walking. Yeah, I know it's an observational study and but walking is so good and the patient's so sedentary and we know sedentary is bad for them. They should get up and walk, even if it's not a randomized trial. We just put our own causation into there. And we do this already. The arguments in favor of this is that it would clarify interpretations of research, and that's the promise of evidence-based medicine. It would simplify goals of the research interpretation and goals of clinical medicine down to unifying principles of diagnosis, prognosis, prediction versus prevention and treatment. And that's it, Alan. I am ready to take questions. Hear what I missed.
Thank you, Steve. Great stuff. Thank you for putting it all together. I can see we already have a few hands. Let me just quickly orient us to the Q&A. So you can ask questions in one of two manners. The first is to indicate with a raised hand, and then I will unmute you and allow you to ask your question. And have a conversation with Dr. Stovitz about that before moving on to the next question. Alternatively, if you would like to place a question in the chat, I will monitor the chat and also take questions from there. So to begin, I've got a question from Lindley Darden. So Lindley, I am opening you up to talk now.
She's on mute.
So Lindley, you're muted. Okay, there you go.
Okay, you can hear me now?
Yes. Go ahead, Lindley.
Oh, well, this is a really interesting lot. Can you hear me?
Yes.
Can you hear me?
Yes.
Oh, okay. I hadn't seen the critiques of evidence-based medicine approach from exactly this angle before. So I really quite enjoyed this perspective. The perspective that I've seen discussed is that you need to know the mechanism between A and Y, as well as having the evidence from the randomized clinical trial, and that it's a critique of the evidence-based medicine pyramid for omitting any knowledge of mechanism. And I noticed you didn't use the term. So can you say something about that?
Yeah. Thank you, Lindley. And what field are you in? May I just ask, just so I can try to remember?
I'm a philosopher of biology, and I write about the discovery of biological mechanisms.
Okay. So I'm sorry to leave out your term and your field. It wasn't purposeful, but I'll explain why I did. So from a prognostic diagnostic viewpoint, I would argue that mechanisms are kind of they're not that important. They can, I don't mean to dig on mechanisms, believe me, to a mechanist, but if somebody told me that 70% of patients of mine who wear blue jeans, are going to suffer a heart attack in the next 10 years, and somebody walks in with blue jeans, it could be because for a million reasons that doesn't have to do with blue jeans causing the heart attack. So from a diagnostic thing, we're just trying to relate two variables to each other. How often does variable B occur when we find variable A? So, and that could be causal or non-causal. The mechanism kind of doesn't matter there. From a treatment standpoint, if you want to know, when it comes to pathways, if you want to know the direct mechanism, then the direct effect, then mechanisms are probably important. As a clinician, I want to know usually the total effect. So the example I'll give you here is if somebody has knee pain and I put them on a strengthening program I want to know, does their knee pain get better? I don't want to know if their knee pain gets better because they have endorphins and that's why they feel less pain, or because their vastus medialis obliquus gets stronger and that's why. When I say I don't want to know, Lindy, I want to be clear. I do want to know, but I think we're interested in total causal effect, regardless of the mechanism. So I think mechanisms are important for future research, but to the clinician in the room, I'm not so sure. But I'm happy to entertain if you think otherwise.
Well, it seemed to me that if you knew the mechanism of why your skinnier people were getting heart disease, and you knew the mechanism by which your obesity ones were, and you could separate the two groups based on the different mechanisms operating, that would solve your problem.
You are correct. I started from you're right. If I knew those things, you're right. I'm starting from, if I just knew that skinnier people have these problems and heavier people have those problems, and I need to discover the findings and I'm with a patient.
Right. I know that finding mechanisms is much harder than finding what happens in the randomized clinical trials, but there's still the question of how good is the evidence that comes out of those trials. So I'll give other people a chance now.
Thank you, Lindley.
Thank you, Lindley. Okay, next question is from Charlie Geyer. Charlie, you should be able to talk now. You're muted, Charlie.
There we go. How about that?
Okay, you're a little bit soft. Can you speak closer to your mic?
Right. I have my mic out of the way. So two things that are maybe related, both related to the problems you raised. I want to say that it's even worse than selection bias, that most people have the view that correlation is not causation, except when I can't imagine why it wouldn't be, and then it is. And that is very hard to get people to stop doing. And so you wind up, whenever the imagination fails, correlation becomes causation. And the other is, a couple of years ago, IRSA had this thing on causal inference, and Miguel Hernan gave a very interesting talk saying that the solution, or a solution to a lot of problems, not necessarily this one, is you need to analyze and report all of these observational studies as if they were clinical trials based on intent to treat. In other words, you have to make a super event. You have to actually attempt to correct for your selection biases and report that. And if you don't, it's a terrible study. So I wonder what you think about either of those.
Well, so I think Miguel does believe that, Hernan believes that we should try to emulate randomized control trials. So when we analyze data, we should go back and try to emulate what we would have done had it been a randomized control trial. I don't know that, I wouldn't say that it would be intention to treat, because in a randomized, I mean, it depends what you're interested in. If you're interested in the effect of randomizing people to group A, then you're interested in intention to treat. If you're interested in the effect of taking A, then you're not necessarily interested in intention to treat. And I don't think Miguel would say it's terrible if you don't do that. I mean, I think he would argue you do the best you can.
Okay.
Thank you, Charlie. Take our next question from Kat St. Croix. Kat, you should be able to talk now.
Hello, hi. Thank you. This was a super interesting talk. And I'm in philosophy, so this will be somewhat unsurprising. But it really brought to mind for me the long-standing debate between causal and evidential decision theory. And I thought the decision theoretic framework is really useful for the kind of problem that you're approaching, which is like, as a clinician, what is the decision that I recommend to my patient? And this in sort of the like, well, I guess the initial question is, are you familiar with this distinction between causal and evidential decision theory?
No, but I would love to be.
Okay, cool. Yeah. Awesome. This is exciting then. So I think the place that I would point you to, there's like a specific article that I can just put in the chat in a moment, but this is like a back and forth between Alan Gibbard and Jim Joyce and David Lewis, all of whom philosophers and economists. But the idea is making this distinction between the conditional probability and the probability of a conditional, and that when you bring that difference into your decision theory, where evidential decision theory kind of tends to simply use the conditional probabilities rather than the probabilities of the conditional, you end up in situations, I think sometimes like this, getting very different recommendations out of the decision theory, even when you're bringing in the same probabilistic backdrop, like the probabilistic data. So I think that might be a really cool place to go for like philosophical buttressing of your arguments.
Love it. Yeah, my email's my last name at umn.edu, so you could also.
Oh, fantastic.
Okay, great. Moving on to the next question comes from Yoshi. So Yoshi, you should be able to talk. Let's see now.
Okay, can you hear me? Good. Yeah, thank you so much for the interesting talk. I'd like to hear a little more about the idea that what you said, the researchers should base their studies on more on problems rather than hypotheses. Maybe I'm not repeating very accurately, but you said something like problems rather than, or instead of hypotheses. And I want to hear a little more like how it would help solve this problem.
Yeah, so the basically, I don't have a well-prepared short answer for you, but I do feel like what happens is, and I'm as Alan alluded to, I'm an associate editor at a few journals, and I'll read papers and they'll have a hypothesis, but they almost don't have a question. So their hypothesis in this one might be, we hypothesize that obese people, heavier people will die fast, at a younger age than less obese people. And that's their hypothesis. But what's the question? Is the question, do obese people live longer? And if it is, do obese people live longer among those with heart failure? Then the answer is yeah, because the people with heart failure who are not obese, had another reason for their heart failure. Is the question, is obesity good for people with heart failure? Then the answer is no. So you can have that hypothesis, but if you don't specify your question, you end up writing. So I see papers, they have a hypothesis, they then do statistical analysis, they come up with a p-value, they say we either that we refuted our hypothesis or we didn't refute our hypothesis, and then they make the mistake of saying the groups were the same, but that's a different issue. But they can refute their hypothesis, but there's no question behind it. I mean, they might have one in their head, but I'm sitting there as the reviewer trying to guess, well, what's your question? And this might get back to Kat's point. Maybe there's a difference of decision, because I'm looking at, you know, what's your question of what I'm supposed to tell somebody? So I look at it, getting back to my second slide about failing medicine and research methods, I look at it like, what am I supposed to tell the patient? And I understand not everybody's research, like Lindley's, might not be on, you know, patient, might be more mechanisms, but even if it's mechanism, what's your question? Is this the mechanism? Not, our hypothesis is these two things would do the same. That I'm not sure gets at the mechanism. I don't know. But getting to a well-defined question with the researchers I work with can take months, like months, to get your question down right. So that's what I mean. I think you can have an hypothesis without a really well-defined question.
Thank you. That really clarifies.
But you can't have a question without a hypothesis, sort of, or without thinking in your head what you're trying to disprove or prove. Mm-hmm. Thank you, Yoshi.
Thank you.
Okay, let's go on to the next question, which is from Ernest Hook. You should be able to talk now.
Muted. Okay, can you hear me now?
Yes.
Okay, thank you. I enjoyed your talk very much. If you'll forgive me, a number of excuse me, questions and comments. I think the most important one is really the possible the question, an adverse effect of the obesity paradox. In other words, to kind of reflect this back to you, so to speak. So what is, let's answer, I think the implicit question in your presentation is, what is the harm in the obesity paradox, and can you study it? And maybe the thing to do is to study clinicians themselves and see to what effect their advice they give to their patients is affected by the obesity paradox, and if you can, see the consequences for their patients. I mean, if you, I'm very concerned about people's, I mean, these crazy responses you've gotten when you've explained this. And obviously people don't understand, but if you can demonstrate the dangers of this, I think this would be tremendously effective. Now, a few other thoughts or comments, but that's the most important. One, I've always thought evidence-based medicine meant two things. One, the requirement for a double-blind assessment of therapy, shall we say. And secondly, barring that, physiological rationale for treatment, such as treating hypothyroidism with thyroid. Do we really need a double-blind evaluation? In fact, would such be ethical? But you also commented on something called, quote, the art of medicine. And you know, I don't really know. I've always wondered, quote, what the art of medicine really is, or how one would define it, or all kinds of things have been, how should I say it? All kinds of horrors or all kinds of mistakes kind of hidden behind somebody who invokes their expertise in the, quote, the art of medicine. I've just done a review of every edition of Osler's textbook from the first edition to the last. And looking in particular at bloodletting. And you know, here was the man who in his time was regarded as the apogee of the art of medicine. But you weep when you see the kinds of things he was endorsing. So anyhow, I'd be interested in your thoughts.
So I don't know. Thank you very much, Ernest. And I'd love to hear about the research with the textbooks too. I think it'd be hard to, document the adverse effect on patients because it would have to go to the studies, clinicians reading the studies, clinicians believing the studies, clinicians changing their clinical management, patients following clinician instructions. I think it'd be, I think it's safe to say we're wasting a lot of time and energy. We've got 3,000 papers on the obesity paradox. It keeps coming up. It's like every week I get this listserv and another 5 or 10, I could write a letter to the editor. And it's just like, I don't have time to do this. I do know clinicians who believe this. And I do have patients who come in and say, but I thought that it's not that bad for me. And I'm like, it's not that bad for you. It's just, I don't think diet would hurt. You know what I mean? Like you do find yourself. So I think that's well down the line. In terms of evidence-based medicine, yes, randomized controlled double-blind studies are the pinnacle for a single study design, but somehow meta-analysis, which is supposed to be more precision on those, taking them is higher. And sometimes we skip those randomized trials. And there's some great observational studies that can find the best evidence. I think the trick is finding the best evidence. Last thing I'll say, and then go to the next questions, is just when it comes to the art of medicine, again, I have no problems with the art of medicine. If the art of medicine means listening to a patient, means repeating what a patient says, means in the days when we could hold hands, touching a patient or whatever before COVID, if that was the art of medicine and if it helped people, to me, that's evidence-based medicine. If it's using a certain language because a person comes from a certain culture or phrasing it in a certain way, to me, that's evidence-based medicine. People have studied that Native Americans may reply, I worked on an Indian reservation a little bit, and I was taught to not phrase things in certain ways to certain populations because it can mean different things to different people. That's evidence-based medicine. If that's the art, it's still evidence,
Thank you. Thank you.
Thanks, Ernest.
Okay, thank you. So moving next to a question from Valerie Tiberius. Valerie, you should be able to talk now.
Can you hear me? Hi, Stephen. That was a fantastic talk. I so enjoyed it. And also found myself quite horrified to know that this is the state of things. I wanted to ask you, I guess, sad to say, I'm a little bit skeptical about the power of education. So I know that there's some good evidence that teaching people about their biases doesn't help them overcome it. It doesn't help people overcome their biases, just pointing them out. People, tend to think, well, yes, I see that other people have that bias, not me. Now, that's not what you're suggesting. You're suggesting a curriculum that emphasizes education about causation. I guess I just want to know, do you have any evidence-based optimism that this education program would be effective?
No. Next question. No, I don't. It's a great question. You just bummed me out because I don't. I've watched medical students for 25 years and teachers of medical students, and they'll talk about this is associated with that and that's associated with that. And then I'll get the medical student and I'll say, well, what should we do? And if there's not a recommendation for the patient, the learner gets stuck. Or if you make a recommendation and the patient asks that awful question of why, the clinician often gets stuck. It's like, because it says so, because that's what the evidence says. And that's where we become really robotic. And that's where people kind of cringe and hate evidence-based medicine. So do I have proof that this would help? No. Do I think it would simplify medical education a lot? Yeah. And mind you, by the way, another thing which I didn't bring up is I was a family doc for about, 10, 15 years. Then I did family and sports. Then I did just sports. And then about 4 years ago, I went back into family medicine. So it's kind of fun because I'm retraining myself and I'm learning, I'm having to like restudy things. I just look at them from this other viewpoint, and I find it to be like way easier. So that's just me. That's only an N of one. But I think that we have sort of a discipline coming from causal inference, and we have this discipline of clinicians coming up. And to me, I just see a perfect synergy between the two, because clinicians, yes, we diagnose and prognose, but we also prevent and treat. We do things, and that's where you should have a causal reason for your actions. So to me, it just fits perfectly. Do I know it would work? No, but should we try? Yeah. Are we doing great now? I don't think so.
I'm very sorry I didn't mean to bum you out, and it's certainly worth a try. If I could just make one quick recommendation. I know some of the people in the College of Biological Sciences, especially the biology teaching professors, have done some work on how to overcome student misconceptions about evolution in particular. But I think some of the techniques they use might actually be quite helpful for medical students. And I could email you about who those people are if you want.
Definitely. Thanks, Valerie. Good seeing you or talking to you.
Thank you for that question. I'm going to now go to the next question from Ruth Shaw. Ruth, you should be able to talk now.
Okay, great. I also really appreciated your talk, Steve. Thank you very much. It was really interesting, and I'm glad to hear Valerie give a shout out to College of Biological Sciences, of which I am a faculty member. So, and I'm aware of that work, which is really valuable, I think. I just can't help but wonder. I have been an editor-in-chief of a journal, the journal Evolution. Like you, well, you gave a mention in passing about predatory journals and the pernicious, sort of alluded to their pernicious consequences. And of course, one of your quotes of in response was all about how many papers these people had and what their standing must be. So there clearly are motivations to keep churning this stuff out. And so I guess I would just appreciate your commenting on that a little bit more. It's a bit off the topic of your talk, I think, but I think it is, we just have to grapple with those aspects in not just medicine, many other fields. I could also mention pharma, the big money of pharma, which of course has done pernicious things in terms of misinformation. So that's.
So I think you're opening up for me to sort of go off a little bit on this. Is that right, Ruth?
Yes. So I mean, I think it's an elephant in the room, honestly.
Yeah, no. So let's see. So Brian Nosek from Open Science in Virginia, and he's the one who repeated all the psychology studies and found that so few were repeatable. And he's gone on to some other things. He has some good ideas, some very, very good ideas. But one, he's gotten to the point where he thinks we should not have peer review at all. We should just put the papers out and let people do it on the internet. I love Dr. Nosek's work. I don't know him, but I find that to be not the way. My answer to it, I guess I'll offer two suggestions. One would be at the university level, and I know you must be high up and some others maybe on this call are too. I really, really, really wish that universities would understand the crisis that science is under right now. There's a lot of things pressuring it, and people could have a lot of complaints. The one that I'm talking about with you right now, Ruth, and everybody, is just the problem in publishing, the problem that there's not good peer reviewers. You don't get compensated to peer review. The medical students and residents are not taught how to peer review. Many of our faculty don't know how to peer review, People, and so the whole peer review process is kind of jogged down. And I think that universities could help to promote academics. So my two answers would be one, would be both of collaborations, one amongst the universities. I think universities should start forming policies for how we promote science as a field and as a discipline, and reward our professors for doing peer reviews, for teaching peer review, for the whole scientific process. The other is the journals. I would love it, this is just my own answer, although some other people have said different concoctions, if reviews stuck with papers and stuck with authors. And so just like the journals got together about, now 20 years ago and said, you can submit your paper to us, we can't stop you. But if you're doing a randomized trial and you didn't enroll that study as a clinical trial to start, we're not reading it. So that's what JAMA and New England Journal of Medicine, all the top journals did 20 years ago. And then it just became the norm if you want to be in the top journals. I think the journals should get together and say, you can submit to us. If you do, your peer review will stick with your paper. Now, there's different subtleties of this. You can have a bad reviewer and we don't want that stuck. It doesn't have to stick in the published thing. But if you find then that a author, because I'll reject these papers and then I'll see them in another journal ignoring everything I wrote and saying, you guys ignored these papers that have been written that have shown that you have a problem, and they just ignore it and submit to somebody else. I should be able to send my review in and say, hey, that paper actually came to me first, and this is what I wrote. You be the judge.
Interesting idea. Yeah, lots to talk about here.
Yeah, of course.
Okay, thank you, Ruth. So I'm coming back. I've got a couple second questions. I'm going to go to Lindley Darden again. Lindley, you can talk now.
Oh, sorry. I should have taken my hand down.
Oh,
But
that's all right.
I guess I should have given some credit when I was talking about the relationship between randomized clinical trials and mutation and mechanisms, because there's a Russo-Williamson paper, it's called the Russo-Williamson hypothesis, that you need to have both in order to show causation. And so I was speaking to some extent from the work that they've done, and they have a nice open source book recently on evidence for medicine, evidence for mechanisms in medicine. And so I do recommend both the Russo-Williamson paper and their recent book looking at that relationship between randomized clinical trials and mechanisms. So I'm lowering my hand now. I hope, is it going down?
It is down. Thank you, Lindley. And
okay.
Great. I just noticed that I missed one in the chat, so I wanted to come back to that one. This was from Jolie Shackelford, who said, in my experience, clinical interactions often aim to manage effects rather than identify and treat causes, which frustrates my inner Aristotle. Is this a complicating factor related to maybe medical education?
So I can't quite see the thing, but from what I think, oh, there we go. Clinical interactions often aim to manage effects. So there's and treat, rather than identify and treat causes. I don't know exactly what you're referring to there. So maybe if you're on the call and you could, are you talking about just what's the proximal issue? I'm not exactly sure how to approach this.
So I think Jolie may have left by this point. I don't see him anymore. So we'll have to maybe follow that up independently. I just wanted to make sure it got mentioned because it had been lost in the chat, and that was my fault.
I actually can go off this just a little bit though. Okay. Because what he may or she may be referring to a little bit is we tend to treat diseases rather than prevent diseases, because so we don't go after the causes of the disease, we go after the disease. And yes, that's a problem. I actually would argue and I alluded to this on a few different slides, that prevention and treatment are kind of the same thing. If you think about it, when you give somebody an antibiotic for a wound infection, you're treating the wound infection with the hopes of preventing it from getting worse. When you treat somebody's hypertension, you're treating the hypertension to prevent the heart attack. So to me, and this may sound morbid, but life is a series of morbidities, and we're all on the pathway, and everything we do, to me, prevention and treatment causally are the same thing. So I think if we framed it that way, maybe we'd pay more attention to the causes early on. But I don't know if I'm answering.
Yeah, no, that's helpful. So I actually have a question that builds out of a comment that Ernst Hook put in the chat earlier on about experiment. So one thing that strikes me about the case study is that if you had somebody who could have said, show me the randomized clinical trial, and you couldn't frog leap from the case cohort studies to the meta-analyses, it seems like you could have blocked this in a certain way.
Mm-hmm.
I mean, is it possible to sort of think about demanding the clinical trial as a sort of, where is that? And that if that's not there, then we should be really worried.
So the problem with that one, I agree that would totally help here. The area that I think it would be a mistake to go, though, is that we always need a randomized trial. So of course, there's never been a randomized trial to show that smoking is harmful in humans, right? So, there's now increasing literature about that many randomized trials lack generalizability. They don't pertain. Think about it for the people on this call. Would you participate in a trial? If you had a bad problem and there was no other treatment, yes, you probably would. But people who sign up for trials are actually different than most people. Most people don't sign up for trials. So sometimes observational studies are actually more generalizable. So I don't think it's that we should demand a randomized trial. We can't randomize everything, and the people who sign up are different than people who don't sign up. And in randomized trials, once you have dropouts, your analysis becomes an observational analysis. You're making observations about the people still in the trial. You're assuming they're the same as the people who dropped out of the trial. So you're quickly getting into a little bit of a tangle there. So maybe we need a new thing other than the pyramid. I don't know.
Yeah, right.
We need a new geographic design or something.
Yeah, good. Okay, so I want to go to one last question from Ernst Hook, because I know that he would like to elaborate, since I kind of took his comment in a different direction than he originally intended. So Ernest, please, one last question from you. You should be able to talk now. Ernest, can you?
Yes.
There you go. Yep. Oh, you're still muted, Ernest.
Can you hear me now? Okay. Coming back to the issue of the experiment, I'm still, the point was with the tobacco work, there was plausibility of the association from work on mice. The association, the carcinogenicity, at least skin exposure. Now, would not there be some experimental mechanism in lower animals, some way of attempting to refute that association by work in lower animals, to at least might not have some effect or impact on refuting people who would still endorse the paradox as grounds not to be disturbed about obesity?
I think that the work in animals would suggest that heavier weight beyond a certain amount is unhealthy. I think that the randomized studies in humans would say the same thing.
Okay. All right. So thank you.
Sure. Thank you, Ernest.
And thank you to everyone for great questions, and to Steve for a great talk and for a good conversation this afternoon. We hope you all enjoyed it, and hope you will tune in next time in a couple weeks. But until then, take care, and we'll see you soon. Bye-bye.